Good morning, afternoon, and evening, everyone. Thank you very much to take the time to participate in this special occasion in HIA Virtual Symposium, Our Interconnected World, Impact Assessment, Health, and Environment. My name is Yina Xiao. I am currently working for Yina, an international oil gas company at Central Asia and Far East region global health reference based in Milan, Italy. And I'm also the co-chair of the health session for HIA. Today, we are in the second day to discuss about the theme of health impact assessment, its application, its evolution, and to explore HIA as a development planning tool to its full potential, as mentioned in the keynote speech. We are standing at this particular moment. The whole world is impacted heavily by the COVID-19 from the beginning of the year. This has huge impact on everybody's everyday life. This pandemic has not only direct health impact, but also huge social economic impact. Today in our session, we are lucky to have several experts to share their experience on how they have used HIA for social response to the pandemic in different levels and provide their diverse perspectives on this topic. So, after the introduction session, 3 case studies will be presented. We will start from Dr. Janis Shandro. Dr. Janis has a co-disciplined PhD in mining engineering and population health. She is a mother, a community health and safety practitioner, and researcher, and a vocal advocate for the health and well-being of vulnerable populations. For over 15 years, she has worked extensively on community health and safety issues with international finance institutions, private sector clients, governments, and communities. She will share a Canadian case study, the value of HIA processes and tools in preparing Indigenous communities for the COVID-19 pandemic. Following, we will have Dr. Mark Divall. Dr. Mark Divall is a medical doctor with postgraduate qualifications in anesthesia, occupational medicine, environmental medicine, and tropical medicine and hygiene. He has been involved in various aspects of health consultancy for the past 19 years, with a focus on low and middle income countries. Today, Mark will bring us his project of COVID-19 framework for community response planning, WeCare program. We will continue with Liz Green. Liz leads the Wales Health Impact Assessment Support Unit on behalf of Public Health Wales. She is a registered UK public health specialist and fellow of the Faculty of Public Health. Liz raises awareness of and develops a health impact assessment and trains, advises on, and facilitates the process throughout Wales. She has worked on advice or quality assured around 200 HIAs of varying strategic levels, complexity, and topics. Today, she will present us a case in policy level, HIA on the staying at home and social distancing policy in Wales in response to the COVID-19 pandemic. After each of the cases is presented, we will invite all experts back in a panel discussion to share their opinions on several interesting interconnected questions. In our session, we aim to give the audience an overall possibility of health impact assessment as a planning tool in the face of pandemic, in the project level and policy level, from developing country to developed countries, with focus on the vulnerable groups such as Indigenous people. In the end of the session, we would like to look into the future together with all of you, based on the experience gained during the specific pandemic to evaluate the possibility and opportunities we're facing today and the possible evolutions in the area of health impact assessment in the future. So, okay, I will leave the space for our first presenter, Dr. Janis Shandro. Thank you.
Good morning, good afternoon, good evening. My name is Dr. Janis Shandro, and I wear a few different hats in my life and as a professional. My title that I've got here is Community Health and Safety Specialist, and I've been working in that field for well over almost 15 years. I also do consulting work for health organizations, both nationally and internationally, for private sector clients, for international finance institutions, for governments and communities. And today I'd like to present a case study with an Indigenous nation that I've been working with for quite some time now. And the title of the presentation is Looking at Health Impact Assessment and How It Relates to the COVID-19 Response. Before I begin, I'd like to introduce some of the co-authors that I've put here because it's really important. Our approach to health impact assessment with Indigenous people is that we do this in partnership. So I've got Mr. Chris Apps. He is the Director of Lands and Resources and actually commissioned the HIA that I'll speak about in a few moments. We've got Ms. Jerry Inkster, and she's the Health Manager for Kitsillas Nation, and Mr. Ken McDames Jr., who is the Emergency Preparedness and Response Manager for the nation as well. So without further ado, I'm going to get going here, and I hope you enjoy this presentation. So we might think, first of all, where is Kitsillas Nation in comparison to Canada? As you can see here on the left-hand side of your screen is a geographical map of Canada, and that yellow dot is approximately the location of some of the communities for the nation. The right-hand side depicts, for the most part, some of the traditional territory associated with the First Nation. And so you can see that it's quite an expansive territory. There's some overlap between other Indigenous nations in the area and communities. But what I'd like to really highlight for you is that actually this is one of the most active economic areas of Canada. We have over 20 industrial projects affecting Kitsillas' traditional territory. One of them including one of Canada's largest infrastructure projects to date, which is a $40 billion LNG facility by Shell and Petronas. We also have an associated $7 billion pipeline build that's running right through the territory. So I guess what I want to say is this is a very, very active region and was part of the reason why health impact assessment procedures were prompted. So to go a little bit on my work for Kitsillas and why I've been engaged by them, the scope of my work is pretty vast. There's a couple of examples here. One is to identify community health and safety issues and risks related to the industrial development projects that we were just speaking about. But mainly we're focused on developing solutions. So as part of my negotiation for the health impact assessment, I actually said, I don't want to do the assessment for just the assessment. I love implementation. I love that aspect of the community health and safety work. And so with their blessing, I came on board to really be able to develop solutions, help them manage risks with the overarching goal of improving community health and safety for the people. I also play a supportive role to Kitsillas leaders in monitoring conditions and making decisions that affect their health and well-being, and that's become incredibly important during the COVID-19 response. Our work in this area for Kitsillas, but also in general, whenever we approach a industrial zone, although not many Canadians like to call it that, I'll raise the flag, such as one that's occurring in the Pacific Northwest of British Columbia, is really we need to draw on some guidance. And I've highlighted two pieces of guidance here that I was fortunate enough to author. One was a health impact assessment framework for special economic zones or industrial zones in the Greater Mekong subregion of Asia for the ADB. And the second one is a guideline for conducting health impact assessment for First Nations in British Columbia, Canada, which was commissioned by the Tsimshian Environmental Stewardship Authority in 2018, of which Kitsillas was a member of. So they were involved in the commissioning of this guideline. And really, when we got together and undertook a bit of a scoping exercise as to what the landscape was, we decided both of these guidance documents were completely relevant for the procedure that we would follow. So there's a bit of a caveat here, and I like to, where I can, raise awareness of the importance of conducting health impact assessment with Indigenous people. It's a different approach than what we would do, perhaps, let's say, for an IFI in a project in Africa or in Asia or Latin America. We advocate for a close relationship, a close working relationship with the people who are affected by the work. And for Kitsilus, this work began in May 2019. The approach that we take is requiring that connection piece, that partnership, because we're dealing with people who have faced an incredibly different experience in terms of their life trajectories. We need a unique approach to address the historical legacies that they've faced. We need to acknowledge that they have unique determinants of health, including access to traditional land, territory, resources, food. We need to acknowledge their unique way of knowing and their knowledge base and systems. And that would be different from a Western scientific perspective. We also need to acknowledge that Indigenous peoples have specific rights to data, and especially through the research process, and this is where health impact assessment falls. And finally, last but not least, we have people who have very unique priorities. For Kitsilus, we're talking about an entire population of just over 700 people left on this earth. Their priorities will be much different than the general priorities of Canada, which has a population of 35 million. Now we move into the procedure, and for those of you guys who know my work, and you'll see a common trend and theme around the health impact assessment process. I'm a fan, I'm an advocate for it needing to be cyclical, especially given the work that I involve myself. So I never look at a health impact assessment as a one-stop shop and that's it. Actually, the HIA process for me will take us right to our surveillance and response mechanism, our monitoring system, and cycle us back into a continued process of risk assessment. And for Kitsilus, and this is an example of a brochure that we had put out to the community members, and a big celebration that happened after the health impact assessment was conducted. We actually had a community celebration focused on let's making health and safety a part of our everyday. And so it informs a lot of the decisions, it informs a lot of the conversations. It's front and center into our negotiations with proponents, and even just day-to-day activities. Now this is pre-COVID-19. As part of the health impact assessment, we set up a monitoring system. The monitoring system was kind of a tripartite arrangement. We've got department data, and I've given you an example of the different departments that are involved in Kitsilus, and we look for a monthly monitoring of that data and information. We also embarked on a more robust household level survey, and because the nation is so small, we needed an approach that really adhered to the ethical guidelines and privacy and protection of individuals and their health outcomes and determinants of health. But this survey really strove for two reasons. One, we wanted to make sure that important data was collected to ensure that actions and mitigations that we took in the future are able to be monitored and checked to make sure that we got it right. But second of all, given the number of industrial projects, not only just active but in proposal, we really felt the need to reduce that experience around external consultants coming to the door saying, hey, we need your baseline data. We need to undertake our environmental assessment. So can we do this? And actually Kitsilus had a number of baseline assessments. And where does that data and information go? It's lost with the consultant. So in this case, we wanted to streamline that process and make it accessible to the nation. We also have a grievance management system, and when you're dealing with 22 projects and more coming on board, there becomes a point where you actually can't have a proponent-led grievance system. it gets much too complicated because people don't know where to go and who's who. So we actually developed an internal grievance management system where we're observing, having the ability to report, reviewing, and providing a response. And we actually have a liaison committee team that works between the different proponents and community members to support this. So to bring us back to COVID-19, a very timely event happened February 2020. We actually completed the first annual Determinants of Health survey for Kitsilus 1 month before COVID-19 lockdown began. So this is actually quite a strategic time point. It informed a lot of our actions and a lot of our conversations around what the risks COVID could place and in terms of designing our mitigations and our strategies around emergency preparedness and response. I wanted to give you a little bit of information from that survey to set the stage so you understand some of the contextual factors that became important. One, I'll draw your attention to the household averages. Actually, what's important here is that on average, we've got at least 2 families per household. And I actually like to stress this because in some cases we've got 5 families, up to 12 individuals living in a house. And the houses are not that big. The average home is about 3 bedrooms, 1 bathroom per household. So when we start to think about isolation, the need to be able to self-isolate, connection with people in your home, this is a red flag. We also want to draw your attention to the basic needs, and that 64% of our survey participants reported having just enough to meet basic needs. So we're already talking about a vulnerable population. When we think about the employment impacts that have happened as a result of COVID-19, the inability to work, the people that are working in Kitsilus really actually do need that income, not just for themselves, but for their entire household. Some health conditions as well that I think are very important to flag. As you can see here, we report on the percentage of households that report at least one person having the following health conditions. We do that very strategically, and that's again to bring some safeguarding to the privacy and protection of health information and data. But as you can see from the data and information we have some people and individuals in homes that are more susceptible to negative COVID-19 outcomes. So this also is very important in our planning and procedures as we move forward with emergency preparedness and response. And now I want to spend the last bit of my presentation talking a little bit about the issues that emerged over the course of the response. I was very honored to be a part of the emergency response team and to provide advisory services to both Jerry, who is the health manager, and Ken, the emergency preparedness and response manager. But this was not an easy time. And to be honest with you, the weight on your shoulders as a team, knowing the vulnerability of a nation, of people, of individuals, and the need to safeguard that is still an incredible sensitive time. So some of the issues that I would like to raise some awareness on, because as I think in my bio, it said I'm an advocate for vulnerable people. This is so important that we understand in this pandemic. Indigenous peoples, their elders, are knowledge holders, and they're incredibly important for cultural continuity. But this also places them at higher risk. We have one individual for the community who is a fluent speaker. He is the last remaining fluent speaker of the traditional language. This is an invaluable individual, and how to safeguard him for the preservation of language for Kitsilus in the future is an incredibly important issue. I also wanted to raise the flag that the Canadian Emergency and Response Management System was not easy to navigate, even for myself as a professional who writes emergency preparedness and response guidance and implements those guidance for major proponents globally. This was not easy to navigate for an Indigenous community. and the financial tracking and compensation frameworks was extremely difficult. I want to raise the flag that Canadian and international protocols for COVID-19 are really developed for general populations. They're not developed for communities where there's only 700 people left on the planet. And therefore, I've always advocated we need to take the high road. Okay, if WorkSafe BC says this and the health authority says this, this is still for the general population. We need to take a Kitsilus lens to all of the protocols and guidance. Certainly there was information overload, and I think there still is. I think we can all agree on that. But you know, when our chief medical officer recommended the wearing of masks across Canada, actually those were impossible to get for Kitsilus. They faced an issue of unavailable supplies for both hand sanitizer and masks. So not only did I become the advisor for emergency response, I also became the purveyor and shipper of goods and services for essential supplies for emergency response. We've definitely faced isolation challenges that are ongoing. We're working on that right now. The community itself does have an option, but it needs a retrofit and an upgrade. We also have infrastructure issues around bandwidth of internet connections and the ability for kids and everybody to work from home. I don't think we're the only ones facing that, but Indigenous communities in Canada are particularly vulnerable to this. We're getting to the end here, but these two pieces are very, very important, and we look to cultural revitalization efforts. The nation has undertook some tremendous, exciting opportunities to reinvigorate culture, to re-engage the youth in important traditional activities, and when COVID hit, it was like all that was going to stop. But actually, the emergency preparedness and response team developed the protocols to keep those going so that they could be safeguarded. And last but not least, we are advocating with our industrial partners the need to review their COVID-19 protocols, especially for those workers, those Kitsilus members who may be living and working in camps and then returning to their community on their days off, understanding that there is a heightened risk exposure. So we've had very, very positive experiences in working with our industry partners in this regard. And so with that, last but not least, I guess I'd just like to say that the value of HIA has been, unprecedented. Our response to COVID-19 is truly our response to health impact assessment. We see this as a cyclical process. There's new issues that emerge continually, and our work continues to identify those gaps in the emergency preparedness and response process, and we refine our actions accordingly when those things come at us. So with that, I'd like to thank you for your attention for this presentation, and I am open for connection either through the HIA conference or afterwards via email. I'm sure you'll get my contact information. Thank you very much. Have a lovely day.
Okay, good day, everybody. So I'm Mark Divall. I'm based in Durban, South Africa. It's lovely to be with you virtually. It's all a bit weird speaking to my computer instead of in front of you. It would have been nice to see all in Spain this year, but I guess our lives have changed. So I'm going to be speaking today about specifically COVID-19. I guess a topic that none of us really want to hear too much more about, but how Anglo-Americans specifically developed a framework for community response planning as part of a program that they called their WeCare program, and how we incorporated elements of health impact assessment into that. So this was done in March, April, at the beginning of this year, basically as the pandemic started becoming a pandemic, and there was a focus onto that. So in response to the pandemic, Anglo-American developed a structured group guidance to support both workplace and community response as part of, like I mentioned, their WeCare program. And these slides specifically will focus on the community response. So each of their operational sites, and I think they have 25 globally, was required to develop a prioritized community response plan. And that needed to be informed by relevant data and analysis, linking the inevitable, obviously, the social health and economic risk and impacts related to the pandemic. So this approach was broadly centered on three pillars. So there was a planning and prevent component, so specifically focused at avoiding or slowing community transmission, preventing local outbreaks and delaying spread. The respond aspect, if there were outbreaks in their specific operational areas, optimizing care for ill patients, minimizing or supporting adverse impacts due to containment measures, and then finally a recovery phase. So here we are in September. Different parts of the world have gone through their respond and recovery phases in different times. South Africa, where a lot of the Anglo-American operations are located, is now starting to move out of the respond phase into the recover phase. So we're moving our response sequentially. So just the broad overview and objectives of the program. It was very much focused on people's lives and livelihoods, like I mentioned, both within the workforce and within host communities. So the way Anglo-American, they have a specific process called their social way, and it views mining sites and host communities as an ecosystem, both mutually dependent on each other. So they don't view mining as a separate entity, only the private sector. They view their host communities, their doorstep communities, as really part of their operation, and stakeholders associated with it as well. So our broad approach really looked at identifying opportunities to partner and collaborate with key stakeholders, whether they be the Ministry of Health, community-based organizations, NGOs, other partners, other mining companies or other private sector companies in that area, specifically partnering with the community as well. We didn't want to develop prescriptive programs without engaging with our communities and understanding their specific needs. And then obviously the workplace, which included our employees and contractors. So it was very much protecting the health and safety of our workers, but also avoiding and limiting the spread of COVID-19 in returning workers. So you look at containment measures. A lot of the mines shut down for a period of time or had reduced operations. So some of the workers would go back to their normal locations if they were working remotely. So maybe rotational workers. And then when they came back to site, there was a potential risk that they would transfer the virus with them. So we needed to focus on that process as well. So the broad WeCare framework was looking at reimagining mining to improve people's lives. That is a broad Anglo-American concept. And those four pillars are mentioned there, related to physical health, living with dignity, specifically looking at gender-based violence as an element there, mental health, and then the community response. And I'm going to focus on the community response element. So sites, recognizing and prioritizing our community response. So sites were required to consider how they will respond to and prioritize actions related to the potential local impacts and risks from COVID-19. And this needed to consider their local contexts and three processes. So anticipating the impacts and risks of COVID-19 on host communities, irrespective of the presence of the mine or company's activity. So these are existing health needs that are within the communities themselves, their systemic vulnerabilities, and the strength of that local health system and the institutional capacity of the governments in these areas, either nationally, regionally, or locally, to support response to the outbreak. And then anticipating the second process was anticipating COVID-19 impacts and risks directly or indirectly related to site-related activities. So basically how the presence of the mine or the site may then impact on host communities or populations. The third process was looking at potential risks to business. We're not necessarily focusing on that within this presentation, but it was quite important in our continuum on the way we recognize and respond and prioritize our community response to consider. So, the modified health impact assessment approach was used to support those first two processes that I've described earlier. And there's just a continuous review process about how we went through the process to show that health impact assessment, or this process that we followed, wasn't purely linear. It was a continuous. So a continuous process where we reviewed the impacts and risks, defined roles and responsibilities, developed and implemented the approaches, and then reviewed our approaches to determine the success or potential failures of what was happening on the ground, to see how changing responses could be tailored, especially to evolving outbreaks. Some of the predictions around how the outbreaks would evolve were either overstated or understated for whatever reason, whether they were related to lockdown regulations or some other factors. Oopsie, sorry, I've got some weird animations there. So anyway, to support the impact risk assessment process on the existing community health needs, a rapid appraisal health impact assessment was completed. So this considered specifically environmental determinants of health, social determinants of health, and health outcomes, specifically based on the IFC preferred approach using the environmental health areas framework. And those obviously linked to relevant determinants of health as they are relevant. So this supported a systemic approach so that health determinants and outcomes could be considered, and the potential associated issues could be anticipated and recognized. So, sorry, the animation's a bit weird again. So our concept was trying to scope in all the health issues that we could consider, so that we could anticipate these and try and recognize where there might be an issue. So the assessment considered specifically looking at the determinants of outcomes, and those are just broad headings that we looked at. So you can see we considered a couple of social determinants of health. I mean, this is quite a standardized approach, and then specific environmental health areas where they didn't have overlaps into those determinants. We looked at the potential impacts, either negative or a potential benefit, or an area we could enhance. Description of different scenarios associated with the potential impact, specific groups that may be more vulnerable to the effects of the impact, and specific evidence to support the appraisal with related references or resources. So the sites could go and review those specifically to see if they were relevant to their contexts. So I'm just going to do some examples around some of the issues we touched on. I mean, there isn't enough time in this presentation to go through a whole range of the issues that we identified. But the appraisal was then reviewed. This rapid appraisal was made available to all sites so that they could review and screen in potential risks and impacts relevant to their local context. And they could then direct their site-specific community response plans considering these potential issues. So that's just a screenshot of looking at economic stability related to social determinants of health, and how we scoped in whether they were indirect or direct impacts, what the potential impact might be, some of the descriptions related to the impacts, specific vulnerable or impacted groups, and then some of the references and resources. So we went through that in a systematic process, looking at the social determinants of health model that I mentioned earlier, as well as the environmental health areas health outcomes model. So I'm just going to grab some water quick. So this is just another example of a screenshot, just bringing in one of the environmental health areas, specifically to communicable diseases linked to housing and overcrowding. And again, I'm not going to go through the detail in this because we don't have the time. I'm more than happy to share this rapid appraisal with anybody who would like it. As an outcome from this, from the rapid appraisal and the sites going through a systematic approach as part of their community response planning, sites additionally conducted an opportunities assessment to determine if existing programs or partnership could be leveraged to specifically support the COVID-19 response. And based on this overall assessment, each site then developed an action plan in the form of an action tracker to guide and measure priorities and level responses. So this is a live document which is continually reviewed, and like I mentioned earlier, in that continuous review cycle. So it links in priority, risks, impacts, needs, and opportunities. So specific elements of the action track included priority actions linked to risks, impact, needs, the target beneficiaries. That it might have been households, where they were located, the number, it might have been a community, etc. Roles and responsibilities of different members of the team, budget allocations, partnerships are linked to third parties, potentially the leveraging elements I mentioned earlier, and then specifically targeting outputs and outcomes so that they can support reporting and evaluation. So this is a really broad slide. Sorry, I went too fast there. This is a really broad slide linking back to those pillars I mentioned earlier, and we separated them into 4 eventually. So planning, prevention, response, and recovery. Again, we don't have the time to go through all those elements, but those are basically summarized elements of the broad response to the WeCare program. So, and these were broadly generic of what most of the sites considered as their bigger issues. Some sites had more contextual relevant issues compared to others, depending on socioeconomic structures, demographics, etc., and the strength of the local health system. So those were the broad elements we considered. So just bringing in some conclusions quickly. So we considered the health impact assessment methodology was very, very valuable to you, that can be used to inform priority interventions to a global pandemic at the site level. So that it incorporated business continuity planning as well as community response planning. The defined methodology allowed for the consideration of the range of determinants of health that not only considered the direct impacts of COVID-19, but also secondary health and social economic impacts related to the pandemic. And the approaches allowed for continuous review and revision as it was applicable. So these plans have allowed for the broad inclusion of COVID-19 response into the site social management plan. So we're slowly evolving away from COVID-specific plans and linking in the new normal, which is COVID, into the overall site social management plans. So really valuable exercise, and more than happy to speak to people who are interested in the response that we went through. My contact details are attached there. So thanks very much, and we look forward to the questions and answer session.
Hi, I'm Liz Green. I'm Programme Director for Health Impact Assessment at Public Health Wales. And I'm going to tell you a little bit about the health impact assessment that we carried out in Wales around the staying at home and social distancing policy in response to the COVID-19 pandemic. Staying at home, social distancing policies are routinely referred to as lockdown. And so that is what I'm going to talk about. And I'm going to discuss the health and well-being impacts that we identified as part of the process, the positives, the negatives, some of the research gaps, the opportunities, our key findings. And I will set the scene a little bit and then tell you some of the actions that we hope to take in the future, or we hope that other public bodies in Wales will carry out. So before I start, the policy itself was introduced by Welsh Government. Now, Wales is a devolved nation in the United Kingdom. It has a population of just over 3 million. And Welsh Government, it has its own government, the Senedd, Parliament, and Welsh Government can make acts and regulations of their own in certain policy areas. And one of those policy areas is for health, social care, which this policy and lockdown and the pandemic falls under. So the health impact assessment, so the aim of it was to better understand the impact of the lockdown in Wales and the who it would affect, so which population groups, and how it would affect them. And health impact assessment in Wales looks through the lens and the framework of the determinants of health. So not just your physical health, but your mental, social well-being, and that WHO, the World Health Organization, definition of health. And determinants that fall outside of traditionally the health sector, such as planning, public services, the economy, and the environment. So the health impact assessment and the policy supports a lot of Welsh Government plans at this moment in time, including the recovery plan to move out of and progress away from the pandemic as it eases and ebbs and flows. And we're now seeing a second wave in many, many countries. And so this work will help better understand the impact of lockdowns as they are implemented, not just in the Welsh context, but hopefully in other contexts, or at least it will share some transferable learnings to other contexts and decision makers. It was carried out in real time from April to May 2020. So the UK went into lockdown on the 23rd of March. And in Wales, it progressed for a much longer period than some of the other UK nations, such as England, Scotland, and Northern Ireland, by a few weeks. And so this assessment was actually carried out as we were in lockdown. And although it was carried out very rapidly in a short time frame, it was comprehensive. So it was participatory. And like I said at the start, it identifies positives and opportunities that may have emerged from this very sad situation where many people have lost their lives, and also identify negative or unintended negative impacts of the decisions and these policies and the ways that they manifest themselves. You'll notice there, green for positive, red for negative or unintended negative, and you will see that play out in my following slides. And HIA is evidence-based, and the evidence that we gathered together and used as a platform for the health impact assessment was a systematic literature review, stakeholder interviews. So Laura Morgan, my colleague, she carried out 13 interviews, and we had 4 written submissions. We constructed a community health profile, demographic details, and also Public Health Wales at the time of lockdown were carrying out a telephone survey, a public engagement survey, and that actually provided us with some quite rich data and quite useful data where we couldn't find anything else through our evidence search. This presentation is going to focus on the major impacts identified only, because we identified such a breadth of impacts across the determinants that if so who's been affected by the population? I will say that actually there are 2 kind of distinct streams to this. So there are those who've been directly affected in terms of morbidity and mortality. And we know that those who've primarily been affected in Wales have been older people, and that they have more significant risk compared to younger population groups. Black, minority ethnic groups have highest mortality, particularly Asian ethnic groups, where they have 3 times the likelihood. Men have higher mortality than women, and as do people who have pre-existing conditions. And interestingly, those who are living in more deprived areas have double the mortality rate. So if you are in a much poorer area compared to a more affluent area in Wales, then we can see those figures playing out. But the HIA of the policy identified that actually the lockdown was a protective measure for everybody. So in that respect, it was positive impact for many, many people, the whole population. However, we did find that there were particular population groups who were more negatively affected or susceptible than others. And some of these you will see mirror those with the mortality and the morbidity impacts. But you will also see different groups. So children, young people, young adults, those in different geographical settings, women, men, adult care and carers. And I'll speak about some of this as we go through. So what were the policy areas that were impacted? And when I wrote the report, we streamlined the impacts and collated them under policy areas such as the economy, business, housing, public services, the environment, children, older people, and transport, social community areas of impact. And you'll see these play through now. The first major impact was for health and social care, really, but particularly around mental well-being. And mental well-being is a cross-cutting theme for this health impact assessment. And you see it as a thread across a number of population groups and spread across quite a lot of determinants. And that's around the uncertainty around the economy. Many sectors were closed and shut down in Wales because they're considered non-essential businesses, hospitality, leisure, many retail outlets, and people were stressed and uncertain about, well, what's going to happen in the future? Will I have a job to go back to? Then there's the social disconnection. Under the policy, people were only allowed to go out once a day for physical activity or for a reason such as to do food shopping. And it made many people socially disconnected and isolated from their friends and their families, as households were not allowed to mix. And for populations such as older people or those who live on their own, you know, loneliness and isolation will have a much bigger impact than for some other groups. Children and young people were negatively affected because they weren't going to school, they weren't having their routines. And for key frontline workers, such as health and social care workers, who were at the coalface, really, of dealing with patients and cases of COVID-19 directly, then, you know, there's a lot of stress and anxiety, particularly if you might be from one of those groups, such as Black and minority ethnic groups, who are more susceptible to contracting COVID and then morbidity and mortality. And also for mental well-being for women, because for many women, they worked from home, they were in charge of homeschooling and home educating. They may be key frontline workers, such as nurses, or work in retail, such as supermarkets. But also they may have caring responsibilities and worry about their parents, their siblings, their children. And also for those with existing poor mental health and well-being, there was reduced access to services and treatment. Again, you know, uncertainty, anxiety, fear of catching or of contracting the virus or being exposed to it can ramp up anxiety and exacerbate existing poor mental health conditions. However, there were some opportunities to reconfigure going forward models of working and how we provide mental health services per se. But that is also true for other health and social care services across GPs, primary cares, e-consultations, for example. In terms of health and physical health, there were also positive impacts around things like physical activity, but we couldn't identify much research evidence because the literature review focused on quarantines, pandemics, social isolation, and they've just not been very well investigated in previous pandemics. So there's just been an absence of any research and robust papers there. So in terms of business, economy and innovation, as our second policy area, I mentioned many sectors were shut down in Wales because they were considered non-essential. And there is a projected significant economic downturn. And we have seen GDP decline significantly, replicated around the world. A number of employers have made people redundant, or they furloughed, what we call furlough, where they were actually, you know, they were supported by a government safety net, but paid a reduced income of only 80% of what they would have received if they had been working. And for the UK, we also have uncertainty around the economy because of what may happen with Brexit, which is the UK's withdrawal from the European Union, which is due to take effect at the end of 2020. And there are a lot of economic models that are saying that actually there may be a significant economic downturn attached to that as well. But again, we won't know that because it hasn't occurred yet. In terms of inactivity for the economy and the sectors that were shut down, the greatest negative impact has been on women, because many women work in the sectors closed down. So hospitality, leisure, non-essential retail outlets, young people, because many young people in Wales work in, again, the same sectors. So retail, hospitality, leisure, and that's a source of income for them as they work their way through education, or they pay for, what they need and their pocket money, for example. And so that a third also in Wales of 18 to 25-year-olds work in those sectors that were closed down. So you could see that there is a huge impact there. But positively, there were these safety nets, so the furloughing, and that protected jobs and well-being. But also we saw an expansion in some sectors, such as supermarkets and online shopping. So there were potentially positive impacts there. And we've seen supermarkets in the UK actually hire more people to deliver food and groceries, etc. And then home working has been a major change for many people. The policy said that if you did not have to go to work and you could work from home, then you should do so. And actually that is being reinforced as a message this very week in the UK. And while home working is brilliant for many people, it allows you to carry on functioning, do your work. It can provide you with work-life balance. It has environmental benefits because people aren't traveling, they're not using transport, they're not in their cars. It also can have some negative impacts for some groups. And that is particularly those who have caring responsibilities. And I mentioned women and parents who are also homeschooling as well. And so that made it very difficult for some people, because if you're working, but you're also trying to educate your child and deal with other caring responsibilities, then that can lead to a very stressful situation. But also some people, some sectors, it's just not feasible. If you are a worker in a care home, for example, you cannot work from home. If you are a driver, by your very nature, you're out and about, you cannot work from home. So for those, it may have had a negative impact. And then digital media use. We've seen again linked to home working, and the fact that we have such fantastic platforms such as Zoom and Skype and Teams, and we can use a different mix of platforms and different apps on our phones and our laptops, is great and has been fantastic in terms of promoting social connectiveness and getting out public information around, the lockdown, the policies, what's happening, the actual nature of the symptoms and what you might need to look for. It can also have a negative impact, and that is around digital exclusion. And actually, not everybody is digitally literate. And in 2019, Public Health Wales published a report that showed 1 in 10 in the population actually don't have access to the internet. But many of those who do not have those poor or have poor digital literacy skills. And that's primarily in like the over 70s and 80s, for example, where they rely a lot on their children or neighbours to help them translate some of this and do these things. So actually it's quite challenging. And for low-income families as well, and for children, there is an attachment to, mobile phones that actually is not always encouraged because it might be too much, and people can actually become addicted to these kind of things. So there are positives, but also there are negatives around digital media use. And then in terms of communities, we've seen a huge rise in the number of people wanting to volunteer to support their communities, to support their neighbours, those who may be socially isolated. And, that was amazing. So as part of the online survey in week 3, 27% of those that were asked and responded said that they were actually volunteering, or they were helping a neighbour, or they were checking on their neighbours, or doing shopping for their neighbours. So, we saw this huge number of volunteers come forward. We saw social mobilisation, an increase in neighbourliness, and sort of a social capital building in lots of communities, which is fantastic. But for the third sector, it was almost a double-edged sword. So they were overwhelmed by a number of volunteers. And so that had to be worked through, particularly around things like digital checks and, to make sure that people were who they said they were. But also they had to sort of shift the way of working. So, to online digital platforms, and still remain delivering services to vulnerable clients who they normally see face to face. And so that was a challenge for them. But also an uncertain future about funding streams, because many charities and third sector organisations in the UK rely on income that is derived from their actual high street shops. So they may have retail outlets which they sell goods, and that is a major funding stream. But of course, that was closed down. So it's been quite challenging. It's been positive, but it has also been potentially negative for them. And in terms of geographical settings around Wales, Wales is actually a largely rural nation. It has a large coastal area where with lots of tourist opportunities. It's got some beautiful areas in Wales, Anglesey, Ceredigion, Pembrokeshire, where many visitors go. And of course, lockdown was carried out and was implemented through the early spring and the Easter period, where many people travel and take holidays, and then through the summer. And so there was a huge loss of income for some of these areas, but they were also hit by a double manifestation where they also, in some rural areas, have poor access to broadband and digital services. But, potentially when Wales was opened up again, after the policy was eased, we did see an influx of many tourists into Wales this year, because people couldn't travel to Europe or the US or visit family abroad. And so, that could be a positive thing for the future, where people may take their holidays in Wales much more regularly, having been here this year, for example. And then for urban areas, if you live in a flat or an apartment, then the times that you're allowed out under the policy was to take physical activity. And for some, there is limited areas for that. If you live in an urban city area and there's no park nearby, then, or any green spaces, then, that's very, very difficult. But for some, if you lived in a rural area, for example, in Wales, where you've got huge green spaces and mountains, then that could have been a positive. Okay, so in terms of housing, again, carrying on from that, as part of the policy, people were required to stay safe at home as a protective measure. But of course, being in your home and the experience that you get under lockdown and under this policy depends on the quality, the nature of your housing, the amount of space you have, if you have a garden, if you don't have a garden, if you live near green and open blue space or you don't, then, that can be very, very particularly if you've got a family, a challenging situation. If you've got children, you live in an apartment and you can't take them out to play with them as regularly as you were doing, then, that can have a negative impact on you and can impact your mental well-being as well as your physical health. And if you have a reduced income because your sector may have been shut down or you're unemployed and you're staying at home more, then you will heat it more, or you will have more snacking, more food. You may use more water, more broadband, and with that comes a cost. And so, that could have an economic impact staying at home as well. And one thing we did find was that actually violence against women, domestic abuse, sexual violence was a major impact. And so those who live in a house or an apartment with the perpetrator of that abuse, it made things very, very difficult, very challenging to leave the home, because you may go to work almost as a refuge away from your situation, but also as an opportunity to seek help. In terms of housing and homelessness, though, one of the major positives of the policy was that there was an end to street homelessness in Wales. So anybody who was on the streets, anybody who was street homeless, they were actually provided with accommodation. So they were found somewhere to stay, be it a hotel, be it a hostel, but the streets were cleared. And hopefully that might be one of the positives that will remain as we recover and renew post the pandemic. We had improved air quality because the number of cars were reduced in some areas, noise reduction. But, there's a picture there of one of the roads in North Wales, the A55, and I know it's only small, but you can see there's no cars on it. But actually the impact may be transient, as now people are using their cars more and they're finding it as a place of safety. They feel safer in the bubble of their own car rather than accessing and using public transport, for example, where they may be mingling with other commuters and other people, and they may feel that actually there's an increased risk to them of contracting the virus, and therefore they feel safer in their own cars. And so we may see an increased car use during the recovery and the renewal. But also, in terms of transport, people were encouraged to actively travel more. So walk to work if you have to go to work, or cycle. And so there is actually an opportunity there for more sustainable travel policies and transport policies going forward. In terms of equality, I've talked about women a few times. They're at higher risk of violence, domestic abuse, sexual violence. They're more likely to have caring responsibilities, including homeschooling. But also, I stated that they're more likely to work in sectors that have closed down or frontline key services. And 47% of the women employed in Wales work in frontline key services. And the three frontline key services I'm talking about are health and social care, so education and childcare services, but also retail and wholesale. So those supermarkets that are classed as essential retail outlets, many women work in those three services areas in Wales. And so they are more impacted than other groups potentially. Those on low income, we've talked about potential for reduced income, but also if you're staying at home and you're using more utilities and the cost of that, you could fall into food or fuel poverty. Mental well-being through stress, uncertainty about making ends meet. And also those on low incomes are more likely to be on national minimum wages that work in, sectors such as hospitality and leisure. And then the impact on Black and minority ethnic groups. So increased morbidity, mortality, but also we saw some examples of increased hate crime, and also language barriers where English may not be the first language and your first language. And so trying to access support and services may be a bit more challenging under the conditions of the pandemic and the policy. Then children, families, older people as particular groups we looked at. Older people, like I said, disconnection from support networks, unable to see close family and friends. If you haven't got the digital skills or digital literacy, or you're not connected, then that makes exclusion and social disconnection heightened. Then there is mental well-being, and the fact that more older people are disproportionately affected and more likely to die because of COVID, if contracted or hospitalized. And so there's this real anxiety and fear about the virus itself. And so, many older people felt that they couldn't really go out, and they actually cocooned themselves for much longer in order to stay safe. For children and families, again, closure of childcare settings, the schools, but also for tertiary education, colleges, further education, universities, and all of these things affect development, your routines, your education, potentially your future life chances and economic prospects, but also that social interaction with your peers. And, for children who are homeschooled and online, we found that actually there was some data and statistics that said that if you were the poorest, then, you're less likely to have access to a laptop or a tablet in order to do your schooling. So there's about 700,000 children in Wales who don't have access to the internet via a tablet or a laptop, which were considered by another 600,000 children to be essential in order to do your schooling. And also the impact of the lockdown and the policy could be positive or negative, dependent on your family relationships and the situation, your housing, and also, your learning environment. So if you come from a poorer family, you may not have access not just to laptops and tablets and mobile phones, but also toys, quality toys, or having a parent who can spend time with you. So, again, it could be positive or negative. So, opportunities for the future. We did identify that actually there are quite a few things that we could build on. So, social mobilization, increased volunteerism, the home working, acceleration, could have positive in terms of climate change, flexible practices, work-life balance. People were becoming increasingly connected through digital media. And in the Public Health Wales survey, 37% of people in week 3 said that actually they were connecting with family and friends more than ever via different digital platforms. And that was a good thing. But we can look at more sustainable models of working and also methods of working. So e-consultations online, that move to, well, do we need to do that? Do I need to go to that place to work, to have that meeting? Or can I actually just sit in my front room and do it like this webinar? And one of the other opportunities we found was around research. There are big research gaps. So the impact on children and young people of pandemics, but also, like, for example, something like diet, physical activity, people's nutritional habits, things like snacking. Are people doing it more? Are they doing it less? The survey in Wales reported that people said they were snacking more. So, will that have an effect on obesity? Will it have an effect on people's, health and well-being going forward? So we did find some gaps, and there are opportunities there for people to, really explore those kind of things. So the next steps, monitoring the impact of the policy. The report can be used to help support other policymakers and decision makers when we get future waves of infection, and if policy needs to be reinstated or not. This can help, support that. And did what we say, has that manifested? We need to make sure mental well-being is considered both now and in the future as we enter a post-pandemic world. And also, you know, the importance of children and young people, because this will have a longer term impact for them. Like I said, for example, what's happened in terms of that education gap could have potentially a massive impact on their long-term futures. And I think, you know, we also have to think about sustainable recovery planning and renewal. The European Union has a Green Deal, you know, that will try and consider things like how do we mitigate for climate change, but also the UK and Wales need to think about the triple challenge of not just COVID, but Brexit and climate change as well going forward. So to conclude, wide range of impacts across a lot of policy areas and determinants, wide range of population groups affected. I've only just talked about a few of them really as part of this presentation. There are research and evidence gaps, but there are opportunities for us to recover and build back better. And for Wales and the UK, we need to think about, well, how can we address this triple challenge so that we get a brighter, more sustainable future for everyone. And this is a slide about the unit, the Wales Health Impact Assessment Support Unit that carried out the health impact assessment, and some of the resources that we have and the website and training, etc., on what we do. We actually suspended all our activities through most of this year to focus on the response to COVID-19, but that's what we normally do. So thank you very much, and diolch yn fawr, which is Welsh. Thank you very much.
Thank you very much today for the very interesting and different cases presented. Today here with us are Janis. Janis is a health impact assessment and community health and safety practitioner and researcher who just shared the experience on Canadian Indigenous community. Also Marx, who is a health expert with a focus on low and middle income countries, just brought us the project of COVID-19 framework for community response planning. We're also very lucky to have Laura Morgan, who works together with Liz Green for Public Health Wales. She has over 20 years experience in research, policy, and communications across the public, private, and voluntary sectors. They have brought us their recent studies of HIA on COVID-19 policy in Wales. We are glad to have the three of you to join our panel discussion for the third health session, leveraging health impact assessment for societal response to the pandemic in the HIA virtual symposium. We have received several interesting questions during and after the presentation, and I would like to use this time to hear your opinions. So we all know HIA is a useful tool, planning tool, as in policy level and project level. What are the added value of having health impact assessments in the face of COVID-19? Maybe Laura, you can explain to share your opinion in the policy level, and Janis and Mark, you can also have your reflection on the project level. Laura, maybe you want to start?
Okay, thanks, Yina. HIA, as I'm sure you know, is a comprehensive and systematic approach to analysing a situation that in this case affects everyone in Wales, in fact the world, and has a wide range of direct and indirect impacts. HIA involves using an established checklist covering both populations and the determinants of health. Although it's often presented as a linear process involving scoping, screening, collection and appraisal of evidence, reporting and recommendations, and ideally a review and reflection at the end, in reality it's actually a dynamic, flexible and iterative process which can be scaled up or down depending on the subject matter. And it has a variety of evidence sources. Traditional research generally relies on peer-reviewed research. HIA is, dare I say it, a more practical approach, and especially in a rapidly evolving situation where in this case there wasn't actually that much peer-reviewed evidence, but I'll come on to that later. So HIAs make use of stakeholder interviews, grey literature such as briefing papers and media reports. But throughout, we quality assure the evidence that we use using our own expertise and also recognised QA checklists. Another benefit of HIA is identifying not only what's present, but also it can identify gaps both in service delivery and, in our case, in policy making, so that it can look for opportunities for future research, such as how people manage when they don't, for example, have access to health services, or services for people who've maybe lost their jobs as a result of the COVID-19 pandemic and can't actually access welfare advice because they can't leave their homes. So clearly being responsive to the new and evolving pandemic is vital, and HIA is a particularly appropriate approach to analysing what was and is continuing to be a dynamic situation.
Excellent. I think it's a very, very comprehensive reflection of utilizing HIA at this phase, especially in the policy level. Very, very important. Mark and Janis, do you have any reflection on this?
Yeah, so thanks, Yina, and yeah, greetings to everybody around the world. Yeah, thanks, Laura. That was really interesting. So we're obviously approaching it really differently from a project perspective. And when COVID was emerging and the support that Anglo American was looking to do as part of their community response planning, we needed to consider how the various health determinants were actually going to be affected by a specific disease outcome. So it was a little bit back to front. Normally, you're assessing part of determinants and specific diseases as part of a project. But now we did it the other way around. We knew this was going to be a new determinant. And how would this affect our response planning, looking at business resilience, but also supporting our host communities? So looking at that, at those broad determinants of health and looking at the health outcomes, yeah, the sites could actually then have an appraisal tool to actually scope things in rather than to consider what the needs would be. So they could closely look at their internal and external context to frame their specific responses based on what the priorities would be.
Hi, everybody. Thank you, Mark, for that answer, and Laura as well. I'll build on that shortly and just say, I think based on the presentation that I gave, it became very clear the value add that health impact assessment had for the Indigenous community that I'm working with. As you know, in terms of the process, the health impact assessment was actually initiated before the pandemic. It did lay the groundwork of our response to make sure that our response was contextually appropriate and addressing some of the vulnerabilities that, had we not done the HIA, we wouldn't necessarily know would be exacerbated by the situation. So thank you.
Excellent. Thank you for all of you. It's we can see a very different perspective that comes from the policy level and also project level, and also which also due to the HIA was done in this particular time. So especially for Janis, that's the HIA was I think it was conducted right before the pandemic was started, and I think for Lara, the study was doing right after the policy was implemented, and I think for Mark, that's your study was conducted to assess the pandemic's impact on the community. So you have all done the HIA during this pandemic time. What's the unique experience that you have having conducted this HIA compared to the hundreds of different HIA that you have done before? Maybe Laura, you can reflect on the policy level.
Okay, well, the main difference Thanks, Yina. The main difference between this and previous HIAs that we've done is the speed at which we did it. As Liz pointed out in her presentation, the staying at home HIA was carried out in a very short space of time, and also within the context of a national emergency. It was also carried out alongside our other public health duties. We were all in the call centre, we were all involved in our public engagement survey, and one of our team was actually the health protection lead for Public Health Wales. In any case, we had to act quickly. We carried out a rapid screening exercise, which was pretty straightforward really, because everyone is involved. But we did identify that some populations were more affected than others. And the scope of our HIA was also pretty broad, so that was challenging in itself. In this case, we found very little peer-reviewed evidence on the effects of COVID-19 or any other pandemic, to be truthful, on specific population groups. So that was quite challenging. But we identified a number of key stakeholders within Wales, and luckily they all agreed to be interviewed within a very short timescale, which is a bit of a first for me, actually. And we used more grey literature than we normally do, surveys and briefings. And we also, as I said, we had some primary evidence from our public engagement survey, which is continuing to run throughout Wales during COVID-19. But of course, we wanted to be as comprehensive as possible, and we needed to agree a deadline for our evidence gathering. But from memory, I think this may have changed at least once. And but this again emphasises the flexibility of the whole HIA process, really. So we worked quite intensively over a very short space of time. We had very good communication within our team. We came up with a detailed executive summary, first of all, for the Welsh Government, and then we followed up that shortly afterwards with a more comprehensive report.
Excellent. So, Mark, you were probably reflecting that this document of HIA that you did in the project level was actually quite different from the proponents usually conducted, because the disease is usually an outcome. That's this time we're assessing this. Only as a disease as outcome as the impact. So in the future, do you see the proponents to assess the pandemic more often in their project-based health impact assessments? What do you think that's added the value to the especially project HIA?
Yeah, thanks, Yina. So maybe just going back, the health impact assessment, the rapid appraisal we did was very much to inform actions. So it was part of the tools that we used as part of a broad community response planning exercise. They were looking at business risks as well, leveraging different opportunities. So it was a small subset of a larger sort of, assessment process that the company used to give support to sites to actually develop action plans and action trackers that they could respond to for their business risks and for the community. Going forward, obviously COVID, I think traditionally, if people weren't considering potential pandemics as part of their health impact assessments at a project level, they were missing something quite major, because outbreak response, emergency preparedness is absolutely crucial. You should be assessing the strength of the health system and the vulnerabilities of your communities, and how a project or a site influences that. If you're missing those components, I think you would be missing quite a bit. And I think the companies that did miss those sort of things would have found themselves quite vulnerable to this sort of to this pandemic. And if they don't take it seriously going forward, they will continue to find themselves vulnerable, because they're not actually going to be preparing with their as part of their ecosystem with their communities and with their governments as broad stakeholders. So I would hope that these sort of things would now become absolutely central. Normally, health is often a poor cousin of environmental impact assessment or social impact as part of the impact assessment sort of suite. and you're looking at environmental health and safety at site, it's often a small h in the bigger sort of HSE SHE components. So hopefully it's a little bit bigger now, because I think a lot of companies would realize how important health can be and what a key cog it is in terms of the overall business. So hopefully it's considered a lot more systematically and specifically part of the monitoring components. COVID's going to be with us. It's going to change. It's going to change the whole way we see the world and the way everything works. So, and we're waiting for the next pandemic to emerge. COVID isn't probably the last. So it needs to be part of our overall monitoring evaluation system about how projects work with communities and vice versa.
Thank you very much, Mark. You're also anticipating my last question about the future of HIA. But I would still like to ask Janis, because her study is more on the vulnerable group, which is the Indigenous people. So especially for those group in the future, the health impact assessments, how the involvement of this part in the vulnerable group will be developing, or will it be considered as a systematic part in the future assessment, especially towards those vulnerable group?
Thank you, Yina. Well, I think, I'll build upon what Laura and Mark have said, and, in our standard approach to health impact assessment, especially when we're benchmarking those by international standards, we should be identifying those populations that are vulnerable. The difference in the approach for Indigenous people is based upon rights and vulnerabilities, but really we have an obligation as practitioners to meet those Indigenous rights. There are protocols in place internationally and, of course, in the jurisdiction of Canada, Australia, and other jurisdictions like the Philippines. So I think, the approach needs to match the context, but I do want to say, we have a tremendous opportunity right now for the future of health impact assessment. Mark had mentioned that we have been struggling in HIA as the small little group of practitioners, and really and truly, today is the day where we need to advocate very, very strongly that we have the system in place that is effective to help communities, people, societies address the challenges of today and tomorrow.
Excellent. I think both Janis and Mark had anticipated my last question. So what do you think after the pandemic phase, this COVID phase, HIA had showed its efficiency and validity as a planning tool, as assessment tool in this phase, and we have a great future? Or what do you think HIA will evolve in the future, responding to other type of pandemic in project level and in the policy level? What do you think?
Maybe I'll start with that. And then hopefully, Mark, you can springboard, and Laura as well, off what I've said. In the short term, Yina, we actually have a lot of work to do as practitioners. There's not a lot of health impact assessment practitioners around the world as compared to EIA and SIA. The demand for health impact assessment is still there. The requirements are still there, but how do we undertake a comprehensive or even a rapid appraisal when we can't travel? What are the opportunities in the near future? And I think this is where us as practitioners need to come together quite quickly and be innovative, use some of the tools that we have and adapt. So we have a short-term imperative. I'll leave it to my colleagues to speak about the longer-term vision.
So, Mark, you want to add on that?
Sure. I was going to let Laura go first, but yeah, I'm happy to jump on. Yeah, I think Janis is 100% right. I think there's real opportunities to look at this, and I think it's probably because the methodology is so flexible. I mean, we use it to inform an action. If we're looking at, so we need to initiate another health impact assessment for a project now. So we will go about that in a traditional way, but it will now be considering how COVID has actually changed that context. And should we be bracketing just into COVID? I think COVID is just another health outcome now that we need to consider. It's part of the new normal. It's just, I mean, a lot of countries I work in sub-Saharan Africa, they're going to be far more, the impacts related to malaria and HIV over the next couple of months are going to be far more detrimental than COVID's likely to be, because of the weakness of the health systems. So we need to see how COVID has affected those secondary impacts and the local contexts around the socioeconomics, etc. So yeah, I mean, it's I think the outbreak, the risk of outbreaks into the future, whether they COVID, whether they cholera, whether they some other novel disease that might emerge, needs to actually become more central to our planning and monitoring and the continuous review. It's like Janis, I'm not sure it was Janis or Laura said, this is not a linear process. As soon as you finish the impact assessment, it doesn't stop. There's actually a management plan and a monitoring element that goes with it. So it should be dynamic. So companies that have done health impact assessments and are doing interventions should be considering how their context has changed and how they're evolving with this new normal, and what will it look like into the future. And it's changing rapidly. They should be doing this continually.
Okay, looking forward to the next pandemic, following Mark's advice. I'm a big fan of traceability for my sins, and it's even before I'd even heard of HIA, I worked in QA, and traceability was a big thing there. And one of the benefits of a systematic approach such as HIA is traceability, and it's especially useful in a dynamic and ongoing situation. Such as COVID-19, where the effects are direct, indirect, and indeed are still being learned. So early last year, the HIA team at Public Health Wales published an HIA on the public health implications of Brexit. In September last year, we published an update, and we're currently working on a second update. The first update utilised a table of impacts that we used in the original HIA. The table, you can see the table in our current HIA. The table sets out the policy areas we looked at and links the policy areas to the populations and to the determinants of health. And it sets out whether the policy was positive, negative, indeed both, and the likelihood, intensity, and potential duration of the effect. And the table also reference to the relevant sections of the HIA. So as I've said, we've used a similar table of impacts for the staying at home HIA, and using the table, the reader is able to track the source of the evidence and how effective it's been on the determinants of health and the population groups. So for future pandemics, where speed will be of the essence, policymakers and other decision makers can easily trace the rationale and the evidence behind the decision, assess its effectiveness and its appropriateness for future decisions.
Thank you very much. I think it's an excellent discussion, and we're very lucky to have all of you, Janis, Mark, and Lara, for today's discussion with those examples that each of you have presented and showed us the efficiency of utilizing health impact assessments in different levels, in the project level, in the policy level. The capacity of this tool to respond to the pandemic, and not only limited to this. And we for sure would like to continue work on this powerful tool in the future, especially in this special time. We hope all of you stay safe. Thank you very much again for today's discussion and your presentation.
Thank you.
Thank you, Yina.
Yeah, bye.
Bye.
Thank you, Laura.
Bye.
Thank you, Mark.